So it's a little bit surgeon's perspective, but it's also a general perspective. I have nothing to declare related to this talk. I do have some other disclosures, as you can see, so research money and consultancy, but none of it's paid to me. There you go. Can you hear me? Okay. So where have we come from? We just heard Jarko. There's a little bit of duplication, but sometimes the importance of a message is repetition. In 2021, the US FDA revised its black box warnings on breast implants to acknowledge the association between breast implants and systemic autoimmune rheumatological and neurological symptoms. That's terrible. You've had surgery for a breast implant and you get an autoimmune disease. Pelvic meshes. We just heard an example where someone put in the documentation for a fictive non-existing total hip prosthesis. In the Netherlands, someone put in, the meshes in which you carry your oranges when you come from the supermarket? They submitted that and they got permission to put that as a medical implant. So just to show you that some of the things that's been happening in Europe and in the world are quite shocking. And patients feel betrayed, and rightly so. Orthopedic domains, neurosurgical orthopedic domains. This is from early in my career. This is 2002. Does anybody remember the capital hip? So most people here are from the spine domain, but there was originally one of the best total hips implants available was the Charnley hip. And then 3M made a clone, and the clone was called the 3M capital hip, and it was a disaster. And the paper published 22 years ago, new implants should be subject to laboratory wear testing and clinical studies before general commercial release. Then we had the horror hips, the metal-on-metal recalls. And again, final opinion on metal-on-metal from the European Commission. New or technically modified implants, and there we come to our equivalents. The market should be made by step. It's stressed that suitable preclinical and clinical studies are particularly important. So, can we do better? This is from the Dutch arthroplasty registry. The 8-year revision rate for total hips. These are regular total hips, and the revision rate, the blue box, is around 3.5% for women. But we will talk about registries in a moment, but this is one procedure with one outcome. So the cardiac surgeons usually have an outcome which is dead or alive, and in this field the outcome is revision or not. So it could be a terrible total hip, it could be doing really badly, the patient could be in lots of pain, but if there's no revision, it's still classified as a success. If you now look at the metal-on-metal implants, the middle one, or the top one in the bottom box, is resurfacing. So Andy Murray, the tenniser, has a resurfacing hip, 17% revision rate, and the metal-on-metal total hips, 22% revision rate at 8 years. So registries can maybe help capture some of this. And this came from multiple registries. This is the Australian registries. And you can see the blue line is regular total hip revision rate, and the yellow line is the resurfacing. So from multiple registries, the data was coming in that resurfacing hips weren't working. And this is from the Swedish registry. You can see the number of hips is the blue bar. And over the years, after all the evidence came out, everybody stopped using resurfacing total hip replacements. And in spine, we failed our patients many times. BAK cages, lumbar disc arthroplasty. Now, some of these innovations then went on to cervical disc arthroplasty, but IDET, someone became very rich from IDET, intradiscal electrotherapy. The company no longer exists. Dynasis, for the lumbar degenerative spine. Now, some of those implants have come back here for vertebral body tethering, but Dynasis came and went. There's the interspinous process spacers. There's the Axialif, the butt screw for fusion of L5S1. So we've got many, many failed hypes, and patients have been exposed to these. And this is a disc arthroplasty. This is actually one of my own slides from more than 15 years ago. We know that these implants can fail, and they still got to the market, and revision of these implants turned out to be very, very difficult. One of the things that I've learned over the last years, I've been president of the Scoliosis Research Society, and that means I've been exposed a lot to other domains, and the important difference between Europe and America is the FDA and the EU MDR. we just heard from Michel, the EU MDR is a law, or from Rolf, it's a law. It's not a body, it doesn't exist as a body. You can't go to the EU MDR and talk to them. Interestingly, in Europe, for the medicine, the EMA, European Medicines Agency, is actually an agency. They're housed in Amsterdam, you can go and talk to them. And the big difference with the FDA, which used to be from a European perspective more restrictive than the European domain, the FDA does everything. It's the notified body where you put your data in. They're the regulator, and they have a remit is to advance public health. And I'll come back to that in a minute. EU MDR doesn't care about public health. It's a law which is looking at safety. And interestingly, the FDA looks at pharma and medical devices. So in Europe, it's a completely different, although we start comparing them, it's a completely different situation compared to the FDA situation. And the FDA has this, for example, the Medical Device Accelerator. I'm going to read it. I don't like reading slides, but this is a thing worth reading. The FDA Center for Devices launched the voluntary Total Product Lifecycle Advisory Program. Here we go. To help spur more rapid development of high-quality, safe, effective, and innovative medical devices that are critical to public health. So the FDA has a mandate to improve public health, which the EU MDR does not. So its primary goal is to expedite patient access to innovative medical devices. Well, that's not the primary goal of the EU MDR. So as a surgeon, I no longer have access to many of the products that my colleagues in America do have access to. And I actually have products that have been taken off the market that I no longer have access to. Then there's the classification in the EU MDR. It's mostly in our case, if you look at spine, it's invasive devices, so implants, but it can be instruments as well. And even a software app falls under the EU MDR. And surprisingly, I don't quite maybe Michel, you can explain, if you look at the table from the law or from the regulation here, all spinal implants are class 3 because it says at the top, spinal implants, hooks that fix the rod to the spinal column are class 3, but I know that hooks and pedicle screws are sometimes 2B, so I don't even know what that is. But anyway, most spine implants are high risk, which means the level of evidence needed is high.
Under the old regulation.
No, but they've become high risk?
Yeah.
Yes.
And what's the rationale?
Yeah. So are they high risk? Is pedicle screws and hooks, are they 3 or 2B?
Yeah, 2B at the moment.
Well, I think Shakespeare said to be or not to be. I mean, that's
So please go ahead.
Yeah. There are a few things which are interesting, which most people are not aware of. One is compassionate use. You're not allowed to use a device in the EU that's not CE marked. However, the minister of a country can authorize an exemption. So this is the exemption from the Netherlands. And you can go to the Ministry of Health and ask an exemption for a medical device. So for in our hospital, for example, we needed to revise a total knee arthroplasty, and the implant was no longer available in Europe, and it was available in the US, and our minister granted us permission within 3 days. However, the company then has to supply it, and they often don't want to, because they don't have this product in Europe. But the ministry can give you the exemption. It requires a description of the use, the indication, an informed consent from the patient, not surprising. You have to show that there's no adequate alternative. You've got to describe the risk, and you need a doctor's statement. It turns out the exemption and the compassionate use is not so difficult for the doctor side. It's very difficult for the others because the manufacturer has to submit documentation, for example, from a US market or the Japanese market, and they must be willing to supply. Another aspect is the customized and patient adapted. I think Tom is here. Yeah. Our hospital is what's called a legal manufacturer, and I think you are in Utrecht as well, so we can actually have 3D printed our own implants. But is it customized, individual, or is it patient adaptable? Because patient-specific rods actually fall under patient adapted, and patient adaptive falls under EU MDR. So custom-made devices are like a dental crown, is not EU MDR, but a patient-specific mass-produced device is. And for example, these are the 3 examples they give. Plates that are 3D printed, cutting guides. I know people in the room here are using cutting guides, 3D printed cutting guides. Orthoses like braces, if they are made in a factory under controlled conditions, they all fall under the EU MDR. So a patient adapted is not the same as patient specific. Can we do better in spine surgery? We're going to talk about registries in a moment, I believe, so I'll skip this, but I think it's quite challenging. Actually, in the hip arthroplasty I showed you, it's simple endpoint for a procedure. But are we looking at a procedure or an indication? Because if you do a low-grade slip, does it matter whether you do a T-lift or an A-lift or nothing at all? It's the outcome that matters. So are we going to register outcomes or procedures? And who should the burden be on when we do register? Because there's quite a lot of problems about all our registration burden that we already have in hospitals. So the American Spine Registry already has overcome some of this, because most of the American Spine Registry, if you are participating, is now what's called auto-populated. The EMR fills the registry. The doctor has almost nothing to do. Whereas all of our registries, we are still filling in forms either on paper or digitally, double administration. You do your hospital administration, and then you have to go to your registry. But I think Spine Tango may be able to start solving that. However, I'm a bit concerned because the burden of registration really is a major, major issue. And most of the time we're measuring the wrong outcomes anyway. And finally, my point I'd like to leave with you is very important. The CanMeds framework for the roles of the medical specialist. There are 3 aspects of the medical expert. Top left, you can see the professional, the communicator. But the bottom left is the health advocate. All healthcare professionals should also advocate for health for our patients. And to be able to advocate, we need to be able to speak up. And that's one of the reasons we're having this session today. And there are people who are doing this. There's 2 members of parliament are very actively advocating changes in these laws. And actually, just in July this year, the European Commission publishes new regulations. So as I think you said, there are some changes in the pipeline, not just deadlines that are being pushed back. But I put it to you that we should play a much more active role, and it shouldn't just be industry going back forward to the Parliament, because they have a vested financial interest. And actually, although they also have an interest in patient care, we also have a significant interest in patient care. I think we should have much more advocacy from our side, whether it's position statements or supporting our patients. And as a conclusion, I think there are multiple examples of how we failed. We've not taken the role of health advocate. The EU MDR is a law, it's not an agency. And I think the current regulation is indeed too restrictive. And the unintended consequences of trying to get a safer environment for our patients is that our patients are no longer having access to cutting-edge technologies. Thank you.